I'm Dr. Kathleen Moore. I'm the Deputy Director of the Stevenson Cancer Center in Oklahoma City, Oklahoma, and a professor of GYN oncology. And today I'm really excited to be talking about advances in the treatment of patients with low-grade serous ovarian cancer. Low-grade serous ovarian cancer is a rare subtype of epithelial ovarian cancer. So it's only about 5 to 10% of serous ovarian cancers. However, you may have, not a lot, but you may have several patients with this disease type in your clinical practices right now because they tend to, not always, but they tend to have relatively slow progression. So it can lead to later stage of diagnosis, but it also leads to what we characterize as a more indolent and persistent course with sort of slow growing, relatively chemo resistant, although I'm going to tell you today that is changing, with a long median overall survival. So the prevalence of patients with this disease, living with this disease at any one time, is higher than one might expect given the incidence of new diagnosis of low-grade serous ovarian cancer. So even though it's rare, you may have quite a few people at any one time surviving with low-grade serous ovarian cancer in your practices. The symptoms are not that much different than high-grade serous ovarian cancer. They're often vague and kind of difficult to pinpoint to this diagnosis. And that's, again, not dissimilar from high-grade serous ovarian cancer, although the pre-diagnostic period might be much longer because of the kind of slower growth rate of this particular tumor. But patients will often present with things like abdominal bloating or early satiety. They might have pelvic pain. They may have changes in bowel or bladder habits. In general, we see a longer overall survival because of the slow growth, which is good, but it comes at a cost. And the cost is that patients with low-grade serous ovarian cancer have this more chronic treatment course. Because the disease is indolent, but also relatively resistant to standard chemotherapy, our patients, unless they've had a really good surgery up front where all the disease was removed, don't experience these deep responses as we do in high-grade serous ovarian cancer that allows for treatment-free intervals for sometimes years at a time. We just don't see that with high-grade serous ovarian cancer, or with low-grade serous ovarian cancer. Patients are on one treatment after another treatment after another treatment for the majority of this time course. I mentioned the kind of clinical pathologic course for low-grade serous ovarian cancer is very different from high-grade serous ovarian cancer. Kind of why is this? Well, it really stems from the differences in the molecular origins and the molecular features of low-grade serous ovarian cancer, starting from the very beginning, starting from tumorigenesis. Remember, high-grade serous ovarian cancer is really fallopian tube cancer in most cases, TP53 driven, often, if not always, starts in the fallopian tubes and stick lesions. We're starting to really hone in on the pre-malignant precursors of high-grade serous. It's completely different in low-grade serous. Low-grade serous ovarian cancer can start either just de novo, and it really would think starts more in the ovary, although I can't say it doesn't start in the fallopian tube, but this is more an ovarian origin. And it can just start and be low-grade serous ovarian cancer, or it can arise in the pre-tumor or the pre-malignant condition is what we would call a serous borderline tumor. We used to call these tumors of low malignant potential. They have a number of names, but these are these tumors that we often detect early in very young women and resect not treated with chemotherapy. And they're usually cured with that surgical intervention, but they can recur, or if they're found in a more advanced stage, they can convert to becoming a low-grade serous ovarian cancer. And there are kind of diagnostic, kind of risk criteria for which patients with a serous borderline tumor are more at risk for conversion to a low-grade serous than others. Some of the things that help us differentiate between high-grade serous and low-grade serous, and then borderline and not, are molecular features. And some of these are helpful and some of these aren't. Estrogen receptor and progesterone receptor are
not helpful really in differentiation. They are different though. We see more experience of hormone receptors in low-grade serous than in high-grade serous. I think the pathologists always test for estrogen receptor, but you don't have to because it's going to be there over 80% of the time. Progesterone receptors are there over 50% of the time. And that is important just to say because we use so much endocrine therapy in low-grade serous ovarian cancer, but going back and testing for estrogen receptors isn't something we have to do. I will note, though, we find estrogen receptors in high-grade serous ovarian cancer all the time, and it doesn't necessarily mean anything. Like, we don't use that to say, oh, I should use endocrine therapy. It's ineffective in high-grade serous, whereas in low-grade serous, it is one of the most effective therapies. So the importance from a predictive biomarker standpoint between the two is quite important. The importance from a differentiation standpoint in terms of is it high grade or low grade is less important. If you look at the molecular profiles, this is where things look quite different between the two. Low grade serous ovarian cancers are almost always not TP53 alters. They have TP53 wild type tumors. Every once in a while, you'll have a patient who has a mixed tumor, and I've seen this where they have both high grade and low grade. But a true low-grade serous ovarian cancer is not going to have TP53. And that's almost a way you can make the diagnosis if you know you have a serous tumor and your pathologist trying to figure it out. If it's TP53 mutated, it's high grade. If it's TP53 wild type, it's most likely low grade. The other key findings with low-grade serous is that they are really driven by the MAP kinase pathway. And so you'll see mutations in KRAS commonly. You will find, and we do look for it because it's actionable, V600E, up to 15% of tumors with low-grade serous will have BRAF. It's interesting, BRAF mutations are a good prognostic finding for low-grade serous, and we actually find them more in tumors of low malignant. And you don't tend to find, at least BRAF V600E and KRAS tend to be mutually exclusive. So that is low grade. MAP kinase driven, lots of RAS and a few RAF mutations. They should not have TP53. That's very much in contradistinction to high-grade serous ovarian cancer, which is defined by having a TP53 alteration. I've spent a little bit of time talking about the molecular differences between low-grade serous and high-grade serous ovarian cancer and made the point that largely low-grade serous ovarian cancers aren't driven by loss of the tumor suppression protein BRCA as we see in high-grade serous ovarian cancer. And that's true. And I have a few patients who have germline BRCA mutations and have low-grade serous ovarian cancer. And I think we kind of talk about it. I think it's just sort of bad luck. I don't really think the BRCA had anything to do with their low-grade serous ovarian cancer, but you do find it. Then you're always like, should I use a PARP or not? Really, no, it's not going to help. But I say that to make the point that don't gate genetic testing on the histopathology. If a patient has the recommendations for referral for germline testing, of course, patients have the option to opt in or opt out, but referrals for genetic testing should be offered to every single patient with epithelial ovarian cancer of any type. So you're going to most likely find hits in high-grade serous, but you will find things in the other epithelial subtypes. And remember, we're not just looking for BRCA anymore. There's a panel of hereditary high penetrance genes that can lead to development of cancers, BRIP1, PALB2, RAD51C, RAD51D, BRCA. We're also looking for Lynch syndromes. And these panel tests can find other things that are kind of yet to be associated with cancers. And so, so please don't gate who you refer for genetic testing based on histopathology. If they have an epithelial ovarian cancer, they should be offered testing. That is the recommendation globally. And it's just one of the few things you don't have to overthink. It's tough, and like breast cancer and others, all these criteria. There's no criteria in epithelial ovarian cancer other than if your patient has it, you should offer testing. And then, of course, if you find something that looks potentially germline, we want to make sure that families offered cascade testing so we can test for that particular mutation in first and second degree relatives and try to prevent them from being our patients in the future. That's like the biggest win we could get as oncologists, is preventing family members from actually ever needing us in the future. That's germline testing. I would say the same thing is true for somatic testing. In low-grade serous, in advanced or recurrent low-grade serous, just like a high-grade serous, we're doing upfront somatic testing to look for actionable alterations. Those, again, are different, as we discussed, between high-grade and low-grade. But we do want to know sort of what's there in that tumor at the time of diagnosis, so we can start to think about, now that we actually have things to sequence, we'll talk about that, how I'm going to think about the therapies I'm going to start for a patient and what I might think about changing to, or those therapies either not successful or cease to be successful in the future. So somatic testing, ideally at diagnosis when you have the most tissue, is recommended. And the findings of those molecular tests are now actionable. They're increasing medications that match, to some of these molecular findings. So we can say they are actionable and not just informational. So I think it's a very different, we're looking into the near future with very different options for patients with low-grade serous ovarian cancer than we've ever had, which is an exciting place to be.
The diagnosis of epithelial ovarian cancer in general can be difficult. And so we ask a lot of our pathologists. So I think one of the biggest kind of pieces of advice, I would say, especially if patients are presenting first to medical oncology as opposed to GYN oncology, but I think this is true even for GYN oncologists to remember, we need to get as sizable a piece of tumor as possible when it's safe, number one, to our pathologists, so they actually can do several, they can make a block and they can have, several slides made, and they can work immunohistochemistry, and they can send some moleculars and really help give you a kind of comprehensive histopathologic and molecular profile for that tumor piece, so you can help kind of streamline your understanding of the diagnosis and the therapeutic implications of what you find. So it really does come down to getting adequate tissue to the pathologist in whatever way you safely can,
so that they can make the diagnosis.
If you're at a site that doesn't have a lot of experience in making this diagnosis, sending it out to centers that will do an overread is really important. I'm in an academic center. We see a lot of patients with gynecologic cancers. Sometimes it's just really difficult to make the diagnosis, and we send it to Mayo. Sometimes we send it to Johns Hopkins, and we get another opinion so that we have more eyes looking at something so we can make the best decision for our patients. Ultimately, that's what we're doing, is trying to figure out what our patient has so we can make the best treatment decisions for her. Hello, I'm Dr. Kathleen Moore. I'm the Deputy Director of the Stevenson Cancer Center in Oklahoma City, Oklahoma, and a professor of GYN oncology. The NCCN really does help, they update frequently to just try and help oncologists across the globe understand and incorporate new information into the treatment algorithm for patients with low-grade serous ovarian cancer. And so when you just think about at the time of diagnosis, for example, I mentioned in the last chapter the increase in use of neoadjuvant chemotherapy, even globally, for epithelial ovarian cancer. Neoadjuvant chemotherapy for low-grade serous ovarian cancer really does not work well. Primary surgery is, if possible, what we prefer. And getting a no gross residual is, of course, the goal, 100%. There's adjuvant therapy in the advanced setting, of course. Currently, the recommendations are for paclitaxel and carboplatin, because that's been our kind of standard of care for forever in epithelial ovarian cancer, for stage 1C through everything, stage 4. And that is followed by adjuvant letrozole or maintenance. There is data for patients who've had primary side reduction and the tumor's been removed, to just go straight to adjuvant hormone therapy, mainly letrozole, instead of chemotherapy. This does not have a level 2A listing, and in my opinion, should really be undertaken with a lot of caution. A phase 3 clinical trial run through the NCI called NRG-GY019 has completed accrual asking this question. So I think just know that there's not randomized data supporting use of adjuvant endocrine therapy, namely letrozole, instead of chemo in this space. Although certain patients request that. I think that's just a shared decision-making decision.
So that's kind of the front line right now.
It may be, some patients with really great surgeries, maybe they're caught stage 3 and they were surgically cytoreduced and they get chemo followed by letrozole. I'm going to say some of those patients just never recur, which is kind of amazing. But many do, with advanced disease, they do ultimately recur.
So historically, we've used the same chemotherapies we've used in high-grade serous, pegylated liposomal doxorubicin, gemcitabine, weekly paclitaxel, etc., and letrozole, although now we use it in the front line, so that's fallen off, fulvestrant, tamoxifen. Tamoxifen does not work as well. But with those, that was like, we just kind of kept that on repeat and kept using whatever we hadn't used, again. And that's what we've done. That's changing. So before we move on to some of the new things that are coming, the other thing just to point out is that in low-grade serous ovarian cancer, the other big difference is that there's really no such thing as platinum-sensitive and platinum-resistant differentiation, like by this progression-free survival of 6-month cut point that we use in high-grade serous. That really doesn't make sense at all in low-grade serous, although sometimes you'll see clinical trials trying to apply that paradigm here. But these tumors are platinum resistant from the beginning. So if someone recurs on letrozole after 2 years, you could go back to platinum. I would not say you were wrong, and I've probably done that. But you also could go right to another endocrine therapy, or if they have a KRAS mutation, as we're going to talk about, go to some of these MAP kinase targeting therapies without having exposed them to another platinum. So this is a very different kind of thought process than the algorithm for high-grade serous ovarian cancer.
Low-grade serous ovarian cancer really have very different molecular profiles than high-grade serous ovarian cancer. And we've known this for a long time. This isn't new information, that these are MAP kinase driven. But we just really couldn't, with the exception of the 14 to 15% of patients whose tumors harbored a BRAF V600E, where of course we use BRAF inhibitors, BRAF MEK inhibitor combinations that we've known about for a long time. We've extrapolated that from melanoma. Other than that, we just said, okay, well, there's a KRAS or an NRAS. Commonly, it's there, just like every other disease site where there's a KRAS, and you're like, yeah, it's there, oncogenic driver, but not targetable. That's what's changing, is that we finally actually do have medications that KRAS serves as a predictive biomarker for. And so this is where I think a lot of those of us that take care of people with gynecologic cancers are really excited and happy to finally have some actionable targets for things to use for these targets that we've known about, for a long time. The first set of studies that was done, big phase 3s here, were done with the MEK inhibitors, trametinib, which, both trametinib and then binimetinib, both selective inhibitors of MEK 1 and 2. The problem was that these drugs the benefit can be relatively short-lived with MEK inhibitors because of just upregulation of mechanisms that lead to resistance. So if you block MEK, you get downstream block of ERK, but this leads to a feedback loop that just feeds back on RAF upregulation, which basically outsmarts the MEK inhibition, and the whole MAP kinase pathway is sort of back up and running again. So you get this sort of temporary block on MEK that does buy you some clinical benefit, but it's just relatively short-lived. And so there's been a lot of interest preclinically and now into the clinic of trying to outsmart that feedback loop that leads to one of the mechanisms of resistance to MEK inhibitors. And this is where combination therapies can be beneficial. And in particular is the new combination of avutametinib and defactinib. So avutametinib is inhibitor of both MEK kinase activity and RAF. So it's a MEK-RAF clamp. So it hits both and blocks one of the kind of feedback loops that leads to resistance. The addition of defactinib, which is a FAK inhibitor, FAK is also upregulated in settings of MEK inhibition as a mechanism of resistance. And so concomitant blockade of MEK-RAF and FAK, the hope was that kind of combination would overcome the mechanisms of resistance from MEK inhibitor alone and potentially increase the response rates, but also importantly, the durability, of those responses for patients with low-grade serous ovarian cancer. So that's sort of where we're going, in this space. I mentioned already that we've had two big phase 3 studies with traditional MEK inhibitors in recurrent low-grade serous ovarian cancer versus investigator-selected control arms, kind of awesome, whatever you wanted to use. And now we have seen results of combination therapies with the MEK-RAF clamp called avutametinib and defactinib. There's been a phase 1 study called the FRAME study, a phase 2 study that was done really to look at both the combination versus single agent. Is avutametinib enough, or do you really need the defactinib? And the RAMP 201, the phase 2, also really looked at KRAS mutated versus KRAS wild type tumors to see if there was a difference. And then the now completed RAMP 301 is the global randomized phase 3 trial that's hopefully going to prove efficacy and help us get this approved globally for patients with low-grade serous ovarian cancer. So a lot of activity. When you think about trametinib and binimetinib alone, I mentioned both of these MEK inhibitors. These were great studies. Trametinib was studied in the GOG 281, the NCI study that I mentioned, and binimetinib was studied in Milo. Big studies, relatively heavily pretreated populations of patients. Median prior systemic therapies was 2 to 3. Response rates with the MEK alone in trametinib was 26%. Binimetinib was 16%. Although I'll caution you to compare those two because trametinib was an investigator-assessed response rate and binimetinib was a blinded independent central review response rates. The duration of response was also different. Again, these are investigator versus blinded review assessments, but about 14 months for trametinib versus 8 months for binimetinib. Median PFS was 13 versus 9 months. Very similar AE profiles, which is something to note. Fatigue, diarrhea, and of course rash, in both of these. And in both of these, 30% of patients who were randomized to the MEK arms actually discontinued due not to progression, but to adverse events. So even though these are oral and targeted, there is a concern for the amount of adverse events that we were seeing. Now bring in the idea of using avutametinib, a RAF-MEK clamp, or avutametinib and defactinib. This was a phase 2 study. Similar number of prior lines of therapy, 3. Pretty good number of patients too. We're talking about 115 treated with the combination, 70 treated with the single agent. So this was a sizable phase 2. The response rate for the combination of avutametinib and defactinib was 31%. This is all comers versus 17% for avutametinib, blinded assessment. So kind of similar to what we saw with binimetinib. Duration of response for the combination was 31 months. Median PFS was 13 months. And common adverse events were somewhat similar. You saw some nausea and diarrhea, just like with MEC alone. We do see increased blood CPK, which is something we have to monitor for when you're using this medication. And you do see rash, although less rash, interestingly, than you see with MEC alone. And the discontinuation rate due to adverse event was about half what we see with MEC alone. So it's so interesting to me. Combination, you often expect things to be more toxic. And if we really do see lower rates of discontinuation due to toxicities compared to MEC alone, makes me feel much more reassured using this combination, in this patient population, that it's not only working, but also, well tolerated, and our patients feel good on it. So there's a number of things now we can select from, for our patients with recurrent low-grade serous ovarian cancer. So I think the key points are to make sure that we have molecular testing. I still do see patients with low-grade serous ovarian cancer, who had genetic testing, which I'm always happy to see, but they haven't had molecular profiling. So we don't know if they have a RAS alteration. If they haven't, we want to get that done. If the tumor is not RAS altered, say it's a RAS wild type, then we have a number of endocrine-based therapies that we're going to go to, in my practice, long before I ever consider cytotoxic chemotherapy. We have recent data by Solmovitz et al. With a CDK4/6 and letrozole with a response rate of almost 30% and very strong durability. And I think everyone had to use a CDK4/6 and endocrine therapy from the breast cancer literature. So is it non-toxic? No. We do have to really pay attention. Those are very reasonable options for patients that we can access with a little work, because they are off-label as of yet, but they work. So that's something you want to think about. In a RAS-altered tumor, you still have that option. That's there. We're going to use it at some point, but we have avutometinib and defactinib. I think the question that we don't have answers to yet is, what am I going to use first, and what am I going to use second? If I have a patient who has measurable disease or bulky disease, I'm probably going to use my avutometinib and defactinib first, because the response rate's so much higher. I want to shrink that tumor. And if I run into issues with tolerability of that medication and I've shrunk tumor quite a bit, then I can move to endocrine therapy and maintain that smaller tumor for a long period of time. But again, it always comes down to discussion with the patient in front of you of risk benefit, this set of toxicities versus this set of toxicities, where they want to start with. Right now, what are multiple oral agents, which can be attractive. Hello, I'm Dr. Kathleen Moore. I'm the Deputy Director of the Stevenson Cancer Center in Oklahoma City, Oklahoma, and a professor of GYN oncology. One of the, I think, important maybe evolutions that we're seeing across epithelial ovarian cancer in general is the potential importance of comprehensive molecular profiling kind of at diagnosis, if at all possible. So sort of what that tumor has at diagnosis, and you can start thinking about how you're going to optimize access to potentially active therapies based on that profile. And that's very different, than the past, where we didn't really have anything actionable for anything in any type of ovarian cancer. And of course, that whole landscape is changing, which is exciting. For low-grade serous, as we've been talking about, we are right now focused on MEK kinase alterations like KRAS, BRAF, and NRAS. Again, BRAF has been on our radar for a long time because BRAF V600E is, of course, targetable, and we've been using that. But that's a pretty small percentage of patients with low-grade serous ovarian cancer, only about 14%. We do see KRAS and NRAS in up to 40, up to 20% respectively, so very much more common to find these alterations, but they weren't actionable until recently. Low-grade serous ovarian cancer is characterized by high expression of estrogen receptors, so we don't necessarily require testing for it to use endocrine therapy. To be perfectly honest, we just sort of assume it's there and use endocrine therapies. Almost all of them are hormone receptor positive, and endocrine therapies can be highly effective in this disease. And so if I kind of know what my patient has, I'm less likely to just use empiric selection of cytotoxic therapies, which largely are ineffective not entirely ineffective, but largely ineffective, in lieu of using things that hopefully have more likely of helping my patient a lot earlier based on her molecular profiles. The sequencing of these new medications, I will say, I think is something we're going to continue to see the story mature around. Number one, I'd be thinking about, could we resect that growth and just reset the clock? So reconsultation with surgery, I think, is important. Or if there's low volume disease, I might start in that setting with an endocrine type therapy, where I'm seeking just to stabilize that, not necessarily needing to shrink it, because it's not symptomatic yet, but I can use something relatively less toxic for a long period of time. If I have a patient who never had a surgery or has recurred with bulky disease, where a robust response would really be important to her quality of life and the type of life that I maintain on effective therapy, then that MAP kinase profile becomes incredibly important, because now if she has a RAS alteration, I do have available to me avutometinib and defactinib with response rates that are over 40% for RAS altered. They're close to 50% actually. So that's a really high likelihood of getting a RECIST response, or even a not RECIST response, but I get 25% shrinkage of a big tumor. Patients are going to feel better. And so I think that's very important. So it really comes down to two now good options. I would, at least one, there's so many endocrine-based therapies I can use. So two main categories, endocrine-based therapies and MAP kinase categories for that patient population. I'm ideally going to use both. Which one I start with, I think, depends on patient factors, disease factors, shared decision-making with the patient, and trying to just optimize how she feels so I can get her to both options, which should ideally work for maybe years. So it's really a nuanced, I think, discussion with the patient. I mean, the side effects aren't particularly low-grade serous. They're kind of just particular to the mechanisms of what we're using. I think everyone knows the side effects of chemotherapy, because myelosuppression, because neuropathy, if it's a taxane, nausea, vomiting, fatigue. I think we all know that. And if you're not really getting responses or a lot of clinical benefit, you have to wonder why you're doing that. Endocrine therapy, many think, oh, it's just easy peasy, but there are a lot of toxicities that are very bothersome to our patients. And this is where I think consultation with our breast oncology colleagues, I ask my breast oncologist, I'm lucky enough to be at a center where I'm an academic center, so I have access to friends in all the disease sites. So I ask them questions all the time about how they mitigate things, and if it's something I'm seeing is normal or not normal. And so phoning a friend can be very helpful to helping take the best care of your patients. I don't think you should be afraid to ask questions, because endocrine therapy can be tough. Patients have hot flashes. They have arthralgias, which can be incredibly bothersome. Bone loss. We have to pay attention to that here. These drugs can work for a long time. These patients are alive for many years. So you can't ignore their DEXA scan anymore. You got to pay attention. And then a risk for thromboembolism. And if you add to endocrine therapy the CDK4/6s, then you can get varying degrees, depending on the agent, of, myelosuppression and diarrhea. So you kind of add that together. So our most effective endocrine therapies tend to be combinations, and they're used commonly in breast cancer. So there's a lot to learn about the dose modifications and mitigation strategies there that are just a routine for them and not for us in gynaecology. So we really have to learn from them to how to utilize these combinations effectively, but they are very effective. So we can't forget that. And then the targeted therapies, and mainly we're talking about MAP kinase inhibitors here and MEK inhibitors. The big one's rash. With MEK alone, trametinib, binimetinib, 30% active form rash. We can mitigate it. There's things we can do, but it's very bothersome to a patient to have this. There's diarrhea. We do have to pay attention to a small but present risk of kind of retinal events with MEK inhibitors. So having multidisciplinary teams with eye care professionals is important. Hypertension, we can see if you're using defactinib, proteinuria, and I mentioned CPK. So it's just, I think we have to understand the side effect profiles of all of this. Nothing is easy, nothing is non-toxic. They're all things that we have to work with patients and our teams to understand the common toxicities and have preventative strategies and rapid mitigation strategies so that patients are feeling good while they're on this medication. For those of you that are in smaller practices or just starting to use these, I would just highly encourage reaching out to your medical oncology colleagues. I just find having a multidisciplinary team to be so beneficial to patients and making sure that they're like the art of medicine of using a CDK4/6 is sometimes different than the package insert. It's in making sure that you're optimizing patient care. I think in GYN, we're going to really know the MEC space and the avutometinib defactinib space kind of better, and everyone and service the resource for the environment as those drugs potentially move out of gynecologic cancers. But the multidisciplinary teams to manage those side effects is really quite important. When we've built those out at our center, and those MDT teams look very different, at different practices. When we're selecting treatments for patients with low-grade serous ovarian cancer who've recurred, there's so many factors that go into that shared decision-making around what a patient and a physician think are the next best therapies. Of course, you'd lead with efficacy. A close second is side effect profiles and convenience for patients. Most chemotherapies, standard chemotherapies, are infused, as we all know. And they require coming in and having a pre-chemo visit and labs, and then either every 21 days or sometimes every week. If we're talking about weekly paclitaxel, patients are getting an infusion. Endocrine therapies tend to be oral. These targeted therapies, MAP kinase, tend to be oral, which in my practice, a lot of times if patients have never been on an oral medication, they're very excited to be on an oral medication and not an infused medication. But I try to caution them that oral doesn't mean non-toxic, and it just can be a different side effect profile, just to set expectations so they're not surprised when perhaps they don't feel as well as they were anticipating feeling, on these oral medications. So without scaring people and being too negative, we do have to make sure that we're setting expectations for what the toxicities are in these oral regimens. They are more convenient, of course, for patients to be able to dose at home. And sometimes once you get them on a very stable regimen, they don't even have to come in every 21 days anymore. You can kind of let them go a few cycles and see them, which helps people feel like they're living their life and fitting me in around their life rather than vice versa. So I do think there's a lot of advantages to oral therapies, as long as the counseling for that is couched in sort of what the expectations are and what things you need to call me about if you're experiencing right away, so that we can mitigate the hot flashes and arthralgias with hormone therapy. We can mitigate the diarrhea and rash with targeted therapies, with MAP kinase therapies. So I think it really just comes down to shared decision making. It's still, we have some science around sequencing that I say I use this and then this, and that is what we were doing. We're not there yet. So at this point, it's really comes down to shared decision making. If you're taking care of a patient with low-grade serous ovarian cancer, I think that the key advice I would say is that the field is changing, finally. And so it's going to be important. That patient's probably going to be with you for many years. It's going to be important. I don't mean this to sound flippant, to kind of keep up, because there's going to be other readouts coming. There are clinical trials running right now, as we're speaking, that are moving endocrine-based therapies, namely fulvestrant and abemaciclib, instead of chemo, into neoadjuvant, trying to get bigger responses so people get to the OR. There's a study going on right now called the Chameleon study, led by Rachel Grisham from Royal Sloan Kettering, bringing avutometinib and defactinib and letrozole into neoadjuvant instead of chemo, trying to get responses to get people to the OR. Those are potentially paradigm-changing interventions for patients with low-grade serous ovarian cancer that I think we got to pay attention to and rapidly change practice should those prove to be effective. The second thing would be, the second kind of
potential big readout coming will be RAMP 301. Right now, the approval for low-grade serous to access avutometinib and defactinib is having a RAS alteration, which we're grateful for. RAMP 301 will hopefully show the benefit of that medication over investigator's choice in all comers.
So I think just knowing what's brewing in this space will be quite important, because it may, our patients live a long time, and the things that are under study right now will read out and will impact how you're taking care of your patient right now, probably 2 years from now. And so I think just sort of keeping up with what's coming in this space, which is a rare tumor, would be my biggest sort of take home. Second take home is please molecularly profile, so we know who our patients are that have RAS altered tumors right now, so they can access this therapy as it's available currently. And then my third take home is please don't gate genetic testing by histopathology. Test all your patients for high penetrance genes. You'd be surprised what we find. You can actually create pre-vibers for even some very low incidence genetic high penetrance delete or mutations and save lives. So those would be kind of my three take homes.